Hello, my name is Oriana Lowe, and I am a pediatric dentist from Los Angeles, California. I am presenting a lecture on dental anxiety. So, to begin with, I wanted to mention that most people that present in the dental chair have some type of anxiety, whether it be from childhood or developed through the years because of their experiences. The goals of this presentation is to understand the nature of dental anxiety, define the difference between anxiety and dental phobia, review the mode of acquisition, how does it begin, or how do people become anxious when they see the dentist, and then finally understanding the consequences of dental anxiety. Objectives of the course, we hope to go over recognition of the signs and sources of dental anxiety, to understand the concept of a dental home, to describe the significant correlations between dental anxiety and parental anxiety. We wish to be able to have the students understand the relationship between general problems and dental behavior management problems. We also would like a good understanding with behavior management skills with shaping and modeling. And finally, we will be reviewing a behavioral classification system that is used commonly today in our dental offices and is also taught in the dental school. So to begin with, what is the difference between dental anxiety and phobia? Many times people confuse dental anxiety and phobia to mean the same thing, but they are not. Those with dental anxiety tend to be uneasy about their dental appointments. They may have unfounded fears or worries. Dental phobia is a more serious condition. People with phobia have a more intense dread and fear of going to the dentist. They are not anxious. They are terrified or panic-stricken when they approach the dental office or know that you are a dentist or in the dental field. So let's review the nature and mode of acquisition. How does dental anxiety begin and what causes it? Klimberg and Broberg did a study and found a relationship between general behavioral problems and dental behavior management problems. Children who have difficulty focusing and or adjusting to activities in the general environment have increased problems complying with behavior expectations in the dental environment. General fears can be an important etiologic factor in the development of dental fears. Some children who have only shown behavior problems in the dental office this may be due to previous negative experiences with dental treatment. So what is characteristic of dental anxiety? One thing that you can look for is cold, clammy hands or fingernail biting. This may be a first indication of abnormal anxiety in children. The dentist behavior should reassure the child and alleviate the parent's anxiety concerning the first dental visit or procedure. A review of the literature from 1982 to 2006 reported dental fear and anxiety and behavior management problems and they found that it affected 9% of children and adolescents. It found that girls were more anxious than were boys. Dental fear and anxiety was more closely associated with temperamental traits such as shyness, inhibition, negative emotions, behavior problems were connected with activity and impulsivity. Dental fear and anxiety may be more subtle than children with dental behavior problems. General fears can be important in its neurologic factors in the development of dental fears. Some children only have behavior problems when they go to the dental office. And again, this may be attributed to a previous negative experience with dental treatment. There is a relationship between general behavior problems and dental behavior management problems. A patient's behavior in the dental office is influenced greatly by the dentist's attitude, body language, and communication skills. If a dentist enters the room with a smile and a happy face and starts a nice conversation with the parents and the child, you will have a better relationship than if you had entered the room with a not so happy face, with a negative attitude, and you went straight to work and told the child to open their mouth. This will bring more anxiety to the first visit than if you were a warmer person and relayed a warmer style of relationship and body language. Behavior guidance techniques that are used are different to meet the needs of the different patients. There are different approaches. Behavior guidance is an art, such as tell, show, do, voice control, positive reinforcement, pre-visit imagery. We will be reviewing those later in the lecture. So what are some techniques for behavior guidance? One, it is important to give appropriate feedback when establishing desirable patient behavior. Positive reinforcement rewards will likely strengthen those behaviors, and social reinforcers, including positive voice modulation, facial expression, verbal praise, and appropriate physical demonstration of affection by all members of the team is very helpful. Phrases such as "you're doing a great job" or "give me 5, you did wonderful today," versus non-social reinforcers such as tokens and toys go further and is more meaningful in appropriately trying to modify the child's behavior. As children grow, it is accepted and known that usually the impulses and fears of the dentist or of anything will tend to dissipate. They become more mature and more accepting. If fear and anxiety is disproportionate to the situation of an unpleasant experience, the child may become uncooperative, displaying disruptive behavior. Dental anxiety and dental fear is not synonymous with dental management problems. It was shown that 27% of patients with dental behavior management problems had dental fear and anxiety, whereas 61 of those with anxiety reacted with behavioral problems. What is the key to successful outcomes of anxiety? So how do we treat this? What are some possible hints on how to work with this anxiety? So it has been proven, for many years that if you appropriately assess the child and family and prepare them to actively participate in a positive manner in the child's oral health care, you will have a better behaved patient, someone that does enjoy coming for their dental visits. Now a bit about parental anxiety. There is a significant correlation between maternal anxiety and a child's cooperative behavior at the first dental visit. High anxiety on the part of the parents tend to affect their children's behavior negatively. The effect is greatest in children younger than 4 years of age. This might be due to the child-parent symbiosis that begins in infancy and gradually diminishes as the child ages. Because children often sense apprehension from their parents, it is best sometimes to have the parents separated from them when entering the operatory or starting to do certain procedures. However, some parents are good at allaying the child's fears and calming them. The goals of dental visits is to help the children to progress easily and pleasantly through their dental office checkups without too much stress. The stress that children experience may be attributed to a few new factors, and this is the child's confident personality. Someone that's more confident may not have as much anxiety. A parent's proper preparation of the child for the appointment, and a dental team's excellent communicative skills. A word about the dental team. If the dental team is friendly, talks to the child in a nice way, the child is more pleasing and more accepting of their visit, versus a team that doesn't speak to the child and just tells them to sit down, open their mouth. Some children, dental office experiences can cause anxiety, and thus the beginning of a negative dental experience. So let's talk a bit about the pediatric dental treatment triangle. Here you see the child patient at the top of the triangle, and then on the two bottom corners you have the dentist and the healthcare environment, and on the opposite corner you have the family members, neighbors, and friends. All these are all interrelated and make up society. So the child influences the dentist influences the child, the dentist and the family have a relationship, and the parents have an influence on the child's behavior as well. Questions you may ask the parent that may be helpful in determining how to treat the child, or just how to know the child. One would be, do you consider your child to be an advanced learner? Does he or she progress normally? Are they a slow learner? What school does your child attend? What rewards and consequences do you use in the home environment? Questions like this, open-ended, will bring out a conversation between the dentist and the parent, and even the child. Preparing the child is key. In many offices, new patient packets are sent out before the patient comes to the office. And for children, a letter that describes the dental visit is a good aid in preparing the child for their first visit. In the letter, you can describe what the first visit is going to entail: taking any necessary x-rays, having examination, cleaning the teeth, and maybe showing them how to brush their teeth. This is an example of a letter that we send out and we have available for our first new patients in their patient packets. Pay attention to the paragraph that says to help your child. We do ask them not to use words like needle, shot, drill, pull, or hurt, because using these words have a negative connotation. And when the child hears these words, it will develop apprehension and anxiety within. The first visit to the dentist is meant to be a good time for the child to become familiar with the dental environment and the dental team. The goal is to make them have a happy, positive visit that is less anxiety provoking. You don't want to take a tooth out on the first visit. You don't want to do a filling or a baby root canal on a tooth for that first visit. You want the visit to be positive. Certain habits are telltale signs of anxiety, such as digit sucking, finger sucking, thumb sucking, sucking on a blanket, sucking on or biting a stuffed animal. Many times, increased anxiety may result in nagging or punishment that often creates greater tension and may even intensify the habit. So this is something that the parents need to be aware of, that if they keep nagging the child and threaten them with punishment, the child will become more tense, and their habit of thumb sucking, finger sucking will be intensified. It has been found that children of wealthy parents are increasingly recognized as a high-risk group. And they have traits such as narcissism, poor impulse control, poor tolerance of frustration. These children may present with different things to help them cope with frustrations, boredom, and anxiety, and depression. And many times they turn to drugs because they can afford it. According to the Dietary Guidelines for America that was published in 2005, which carries on today, it does recommend that children and adolescents have at least 60 minutes of exercise of moderate intensity 2 to 3 days of the week, if not daily. The benefits of regular exercise include weight management, muscular strength, cardiorespiratory fitness, bone mass, controls blood pressure, anxiety, and self-esteem. This is also true for adults. The other mode of acquisition that can bring on anxiety are certain words, such as hospital, hospitalization, surgery, a cut, a stitch. Hospitalization is a frequent source of anxiety for children. A mere presence of a new or unknown place or instrument can also create anxiety. Parental anxiety concerning problems associated with children with special health care needs frequently delays dental care until oral disease has developed and pain ensues. So basically, many times the parent should be bringing their special needs child more regularly to the dentist and not irregularly. Dental fear and anxiety is not synonymous with behavior management problems. In a study made by Getz and Weinstein, who studied 36 children between the ages of 3 and 5, they found that the longer the restorative phase of treatment or dental fillings, the greater the likelihood of a stress fear reaction. The average amount of time that a child will sit well in the chair is between 35 and 45 minutes. Beyond that, you're going to lose. The child usually gets anxious and they don't sit well after that. Many people avoid dental treatment for themselves or their children because of their fear that the dental visits are painful. Dental professionals should use every opportunity to help patients or parents to overcome this barrier and establish a dental home early. What is a dental home? The dental home is a place that the family, child, and all members can call their dental visit. It's a place that they can get routine dental care. They can call, and if they have an emergency, the dental office will see them as an emergency patient. And it's a place where the parents can freely ask questions of the dental team on dental development, how to take care of the teeth. They can ask questions about their own teeth and what are good techniques of good oral hygiene, brushing techniques, flossing, using fluorides, etc. Early examinations followed by regular recall exams often contribute to children's becoming excellent dental patients because of periodicity. They get used to the visits. They know that the visits are not going to be hurting or that the visits are fun. So what factors influence a child's behavior in the dental setting? Many times it's the maternal anxiety and paternal anxiety, more so the anxiety that comes from the moms. Medical history, if the child has had a history of surgeries, hospitalizations, this will cause the child to be anxious in the dental chair. And children that know that they have a problem in the mouth, they will be more anxious or distribute more dental anxiety when they come to the dentist because they're afraid of what the consequence of treatment may be. And finally, negative influences from family members or peers. Many times family members such as brother, sister, cousin, uncle, and aunt may paint a negative picture to the child, especially if they know the child is going back to the dentist for a filling. Other factors that influence a child's behavior is the presence or absence of parents in the operatory. Presence or absence are beneficial because if they're in the operatory, it allows the patients to participate in the dental exam or treatment in a positive way, we hope. It offers very young children physical and psychological support because these young children know that mom and dad are still with them. And it gives the parents the opportunity to observe the child's treatment. There is considerable evidence that emotional disturbances may be a causative factor in some cases of rampant caries. These children have been observed with repressed emotions and fears coming from dissatisfaction with educational and social achievement, rebellion against a situation that has happened at home, a feeling of inferiority or a traumatic school experience, general tension and anxiety will all cause heightened fear and anxiety. So how do we treat patients with dental anxiety? So one of the ways that we treat them is with protective stabilization. And what is this? The protective stabilization is the restriction of the patient's freedom of movement with or without the patient's permission. It is used to help decrease the risk of injury while allowing safe completion of treatment. Many times the child will be very apprehensive, the arms will swing and the legs will kick. And this can hurt the dental team members, the dentists, or even the parents. The restriction for stabilization may involve another patient or another person as the stabilization device, or a combination of the device and the person helping to hold the arms down or the feet down. The use of protective stabilization has the potential to reduce or produce consequences such as physical or psychological harm, loss of dignity, and violation of the patient's rights. Many times, a device is used when the child becomes combative, and that is dangerous, especially if we were trying to undergo some treatment or even look in the mouth. A combative child can hurt the dental assistant, the dentist, mom, or dad. Here are some examples of protective stabilization. On the upper left, you have the papoose board in blue. This is the common board that you'll see in many dental offices and pediatrician offices. In the middle, you have the mother of a child, an Indian child, and it was typical that children be mobilized in papoose boards for their safety and ease of carrying. On the right side, you see a high-end papoose board that was made for their beautiful daughter. These are examples of another type of stabilization. This is one for infants. You see the 4 straps on the board, the 2 for the hands and 2 for the legs. This is very helpful when an infant needs their first set of vaccinations. Instead of having the nurses hold the child down, this stabilization device can help restrain them. In the other picture, you have the dentist and the father facing each other with the child's legs straddling the father's waist and his head on the lap of the dentist. This is a great way of doing an exam because the parents can see everything that the doctor is telling them about their teeth. They can see in the mouth, they can look at the teeth and ask questions on the spot. These are other types of immobilization devices, a lap cushion, where you place the infant on the cushion, and the cushion is placed between the dentist and the parent's lap. The center picture, you have mobilization devices for the arms, because many times a apprehensive child can throw their arms up and swing them, causing injury to the dental team the parents or the dentist. You have an infant wrap shown in the upper right corner with a head stabilizer. So again, protective stabilization, when used, you must be careful because sometimes with straps that go around the chest may be too confining, and it may cause respiratory arrest or cause them to have difficulties breathing. So you have to be careful when you are using these devices. Management of the child for anxiety, many times we do use pharmacological management, including nitrous oxide oxygen, sedation, and general anesthesia. Several behavior or anxiety assessment profiles have been developed to help the provider or the dentist decide what approach is appropriate to use on the child. The reduction in anxiety may produce the amount of analgesia required. So this means that as the child gets used to the dental visits and coming in for dental treatment, many times if the visits were used with nitrous oxide oxygen were used at the beginning, many times you can decrease or not even use it towards the end of treatment because the child will realize that there is no pain, that everything works, and they become a good patient. So a bit about the behavior classification systems. Many of us use the Franco system. It categorizes the patient according to their behavior. Number one is definitely negative, where you have refusal of treatment, crying, and fearfulness, or any other overt evidence of extreme negativism. You have number two is reluctance to accept treatment, uncooperativeness. Number three is a positive attitude, acceptance of treatment, but with cautiousness. They're willing to comply with the dentist and at times with reservation, but in general follows the dentist's directions. And four, definitely positive. A good rapport is developed with the dentist. They enjoy the dental treatment, and they laugh and they talk and they share things. So a shorthanded form that can be used for Franco is definitely negative as 2 minuses, or number one. Negative is 1 minus, or number two. Positive is 1 plus, or number three. And definitely positive is a number 4 with 2 pluses. The shortcomings of this way of taking your notes is that not everyone will understand it. It's best to write and describe the behavior management technique, so the next time you see the patient, or if another provider sees the patient, they can read your notes and act accordingly. Modeling procedures using AV techniques or live models have been very helpful with the dental team. The dental team also helps to shape the behavior or teach the child how to behave by acting out positive ways of accepting treatment. They stimulate new behaviors. They facilitate behavior in a more appropriate manner. They try to inhibit inappropriate behavior due to fear, and all with the goal of extinction of apprehension or anxiety when coming to the dentist. Other strategies include ask, tell, ask. The ask technique involves inquiring about the patient's visit and feelings towards any planned dental treatment. Tell encompasses explaining the procedures through demonstrations in non-threatening language appropriate to the cognitive level of the patient. And ask, inquiring again if the patient understands how she or he feels about the impending treatment. Behavior management techniques used by the dental team includes shaping behaviors, modeling, and role-playing. Patients have shown that are shown positive photographs or images of dentistry and dental treatment before the dental appointment is an example of positive pre-visit imagery. Like dental books, your first visit to the dentist, it will have pictures of a dentist's visit. You can go on YouTube and download First Dental Visit for the child and have them watch it on YouTube. Tell, show, do has been a proven effective technique in patient management. You tell the patient what you're going to do, you show them what you're using, and you do it. Distraction techniques used by the dental team and dentists is very effective, especially when preparing for an injection. Other considerations to be cognizant about is scheduling. The best time to schedule a patient is in the morning when patient is fresher, dental team is fresh, and so is the dentist. You may have to decide when to separate the parent and the child. It's a judgment call when to ask the parent to leave the child alone with the team. Tangible reinforcements can be a good gesture to get them to behave. If they want that balloon or a special toy from the toy chest, they won't get it until the procedure is completed. And dental attire, bright, colorful uniforms are more pleasing and more accepting than white jackets. And that concludes the lecture for today. If you have any questions, please feel free to send me an email. Thank you very much for your attention, and I look forward to hearing from you. And it was very nice to have been able to share with you today. Thank you.